Hello everyone, here I am in Connecticut. Today I had an interview with Professor Nanda. He is the head of Orthodontic department at the University of Connecticut. It was a pleasure for me to meet him, to visit the residency, to talk to postgraduate students. They have 3-year postgraduate program in orthodontics. Every student has his own dental chair, his own equipment, his own working place. They don't often use removable functional appliances during the course, but I think it's really a great place to study edgewise technique. And now I'm going to share with you some part from our discussion, and I hope to see you soon, next time in Pennsylvania.
This is another most important man in orthodontics. This is also the original book from Calvin Case. Look, and this one is Dental Physiology, 1898. This is one of the classic books which came out about 15 years ago. But everything written in this book is still good. Okay? After that, we came up with this book, which has already been translated in Russian, right? This is a new book which is coming out this next month at a American Association meeting in Orlando. It is going to be an atlas of complex orthodontic patients. So no write-up, just bullets, points, and each and every patient described right from the beginning, each step of the treatment and how everything takes place. And then this is the other book which we did a few years ago on current concepts in orthodontics. So just to give you an idea.
What have changed in the learning process since time of your graduation till now?
Since I graduated? Well, the basic changes in orthodontics have only been at the level of diagnostic criteria and as well as the way we use appliances in the mouth. When I learned orthodontics, we use bands, we use stainless steel wires, and we use cephalometric films. In this day and age, we have CBCT, we have digital technology, we can look at and analyze our patients to do a better diagnosis, a better treatment plan, a better mechanics plan, because now we can bond the teeth, we are using memory alloys, and University of Connecticut has been in the forefront of memory alloys because we are the ones who introduced Chinese NiTi, TMA, CNA, and thermal wires in orthodontics. So we are very active in that area. So we feel that the major changes have been in this area. What our emphasis is to cut down the time it takes to do orthodontics. So in this day and age, if we use proper biomechanics without the side effects, if we use some of the newer methodologies, we can really accelerate orthodontic treatment.
How do you think, who is the most relative thinker from the orthodontists of the past?
I always go back to what I call the real stalwarts in orthodontics. And I'm not going to go back to the days of Angle, but I personally think Tweed, Ellen G. Brody, Ricketts, Jarabak, Burstone, I think these individuals really did a lot for orthodontics. There have been a lot of followers, there have been a lot of, but they are the basic leaders in orthodontics. So, because what we are doing now is they set the foundation for us.
My next question will be about temporary anchorage devices, which is very useful in many situations. Could you please tell me about the development of this method?
Temporary anchorage devices just came into orthodontics about 20 years ago. And I used to be the chairman of the Council on Scientific Affairs of American Association of Orthodontics at that time. And we were looking at the table clinics, and one of the table clinics was from one of the doctors from Korea, in which he was using small pins and these pins he was using to intrude the upper incisors. And from that point on, it just basically took off, because if you can intrude the incisors, you can do better things. I call it use and abuse of temporary anchorage devices. I like to use temporary anchorage devices when I cannot do certain procedures efficiently in my patients, such as closing open bites, such as en masse retraction of the teeth, or such as patients, multidisciplinary patients who are missing multiple teeth, where you don't have posterior teeth and you want to create an anchorage. And I also use skeletal anchorage quite a lot, because with skeletal anchorage I can do major movements. One of my colleagues, Junji Sugawara, who spent time with me here in 1980, he developed SAS system with me. Dr. Kelesh from Turkey, he worked with me in early 90s to develop intrusion of the posterior teeth. So we have been very active in the area of TADS. And once a year, there is a meeting which we organize, which is the World Implant Orthodontic Congress. I was the president of that 2 years ago in California. Last year the meeting was in Dubai. And this year this meeting is going to be in Goa, where we have every expert, about 30 to 40 experts in the area of implant. They come in and they talk about newer things. So this field is still very young, and a lot may come out of it, because we can really accelerate treatment in some patients.
But are there any side effects of TADS, and how we can avoid it?
There are no side effects of TADS. The only thing one has to be very careful of is that you are using a proper biomechanics. Because a lot of times when people use TADS, they think biomechanics is not important. It is rather more important. Such as if you are using TADS on left and right sides, your force has to be equal, because I see a lot of times individuals start having problem with canting of occlusal plane, because one TAD may be too far away from the brackets, the other may be closer. And similarly, a lot of times we misuse TADs. Other than problems related with TADs becoming loose or sometimes get broken, but that is more related with the experience of the orthodontist.
And what is your attitude towards Melvin Moss' concept of functional matrix?
I think the functional matrix concept is an important concept, but how much influence it really has depends on the environment. And the environment is going to take over. So if there is any imbalance between the muscles and the tongue and the teeth, you are going to find some problems taking place. So from that viewpoint, Mel Moss was a pioneer in showing us that how our physiology, how our breathing is all that important. Because now you can see, after a big gap of years, suddenly the sleep apnea has become very important, the mouth breathing has become very important. So now we are realizing that these are all aspects which are problems created by the imbalance in functional matrices.
What is the rule for achieving good stability?
The rule of achieving a good stability is understanding a patient's malocclusion, why the malocclusion is there. So if there is a cause associated with the malocclusion, you got to get rid of the cause. And if you find that oral cavity has an issue, such as tongue or the musculature, you have to deal with that also. And then the third thing, which is very important, is what mechanics you are going to use to correct the problem. And those mechanics without side effects, and how you are going to fit the teeth in the mouth, and how their axial inclinations are going to be, and whether you have respected the tongue and the muscles, that is going to determine the stability. It's not important to put all the teeth together without knowing the surroundings of the teeth. So it is mechanics It is physiology, it is good diagnosis, good treatment plan, good execution. That is what is important.
When would you first like to see a child for a consultation?
I think this is a difficult question. I tell you why. Because I think there's a lot of abuse in the system by treating children too early, because a lot of times orthodontists don't want to lose a patient, and the patient comes in, he's 7, 8 years old, and they put some brackets in the mouth and they do a phase 1 and then they charge again. So I feel if there is a periodontist or dentist has to be informed about it, that if they see cross bites, if they see severe asymmetric issues coming up or jaw growth issues coming up, then they should refer the patient to orthodontist as soon as they can, or a class 3 patient. But I really don't believe in doing early treatment. So I would say I like to see a patient at the age of 9, 10 years, but I usually do not like to start treatment unless there are growth issues, until I would say the teeth have started exfoliating, a early transitional dentition. When the canine is ready to come and the primary molars are getting loose, that's probably the best time to start, unless there are growth issues. So our program is not technique oriented. We feel that when you teach students orthodontics based on a technique, then the personalities come into the picture. Then somebody says, I do rickets, I do bioprogressive, I do Roth. And we feel that's the wrong way of doing it, because there is always a better way, and that is a biologically based and biomechanics based orthodontics. So there are good things with all the techniques, there are bad things with different techniques. So we do a system which is our own system, and that is biomechanics based edgewise orthodontic practice. And so that is our way of doing it. We use functional appliances sometimes, we may use bionators, we may use twin blocks in young patients, because we feel that some patients can benefit from these appliances as the growth may express a little bit faster. We don't think that those appliances grow mandibles, but sometimes growth, they can facilitate expression of growth in patients. We do a lot of orthodontic surgery, and we think we are leaders in the area of surgery first. And we are also very active in using all different types of new techniques and doing different studies to see what is good. So all the orthodontics what we teach is what we call is evidence-based.
And could you please give an advice to postgraduate students and young specialists in orthodontics?
I think my advice to young specialists is that what you learn in school, in your graduate program, is only the beginning, okay? If you think that is going to be set in gold for the rest of your life, you are mistaken. Orthodontics is evolving very fast. We are coming up with new things. We are coming up with new knowledge. We are working on mice. We are working on higher animals. We are working on patients. We are doing RCT studies that how we can do things more efficiently, more economically, and more faster. And that means you have to have an open mind to change your bracket system, change your wire system, change everything. But oftentimes in orthodontics, a lot of people don't want to change. And the other thing is, always go for continuing education and be very critical who you go to, because there are a lot of people who are out in the world teaching and they have no basic knowledge of teaching or techniques or anything. So one has to be very careful who you are going to learn from, what you are going to learn, and always be open, attend meetings. That's my advice.